thank you. So, friends and colleagues, it's indeed a great honor and pleasure for me to be here today. And I'll be moving it, but it's not moving. Let's go back. So we all understand that coronary artery calcification is age and sex dependent. In fact, it occurs in 90% of men who are above the age of 70. And as been alluded, when we are doing a PCI in a heavily calcified artery, we worry about procedural failure and complications. And when we do not properly prepare our bed and take a stent, often we face difficulty in stent delivery, and during stent deployment, there may be underexpansion, asymmetric expansion, or malapposition. And indeed, coronary artery calcification is quite common. In fact, it is present in around 30% of all patients who undergo PCI. And as we tackle more difficult cases, do more elderly patients, patients with diabetes mellitus or chronic kidney disease, there is going to be a steady increase of coronary artery calcification. The good news is that we've got great tools to treat coronary artery calcification, and we've got algorithms, and algorithms where we use imaging to guide us about how to tackle that calcium. But what if the calcium is of such an extent that we cannot even cross our imaging modalities to see the calcium? And that can happen in heavily calcified vessels. And even our smallest sized balloon will not go. What then? And at that instant, rotablation is the only thing that can actually salvage the situation. Why? Because by plug modification, it allows us to gain a sliver of a lumen. And through that access, we are able to pass our hardware, prepare the lesion properly, and that enables us to do the procedure successfully. For instance, in this case, 99% osteal lesion. We all understand that we will not be able to prod with a balloon in this lesion. The patient will just go into arrest. So what did we do here? We did rotablation from the left main to the LAD, the left main to the LCX, prepared our lesion well, did post-dilatation after we deployed our stent, and the result was satisfactory. The next case, a patient with end-stage kidney disease. The vessel is so heavily calcified that we could see the tram track. The pictures are not coming. So we could see the tram track calcification extending through the entire lesion. We wired the vessel, and we knew that without rota, we would not be getting anywhere. So we did rotablation, and we stepped up first with a 1.5 burr, and then when we went up with a 1.75 burr. After that, we did sequential pre-dilatation, went up to high pressures with NC balloons. Only after we had done a thorough job of rotablation through the entire length of the vessel and also pre-dilatation did we take our stents. We deployed our stents sequentially, did post-dilatation, and you can all agree that we would not have been able to achieve this result without rotablation. Now, this third case was a gentleman who underwent bypass surgery 2 years back. Unfortunately, all his grafts had occluded, and you can appreciate the severity in the native vessel. So we had to treat the native vessels now. What we did is we first treated the right coronary artery. After treating the right coronary artery, we went on to tackle the left coronary artery. So it was quite a challenge for us to tackle the left coronary artery because of the huge chunk of calcium which was sitting there, and wiring the vessel was quite a bit of a challenge. We managed to wire with the help of a fine cross and our routine wire. It's stuck again. Sorry about this. So we managed to wire. The pictures aren't moving. And so we wired, and then we did rotablation. After rotablation, we did pre-dilatation, and we could see that there was still a lot of calcium left, so we had to step up our bar, actually. It's just sort of jumped. Can we go back, please? This is the... I'm sorry about this. It's not working very well. And in this case, we decided on a single stent strategy because the LCX was free of disease. We could see by imaging. So we used a single stent, and the final result was satisfactory. Now, this case, this was a very elderly lady, and from the very beginning, we knew that we would use a double stent strategy here. So we staged the procedure. We tackled the right side first, and after that, we went on to tackle the left side, very heavy calcium. And here we had to do rotablation both for the LCX as well as the LAD, and we had to step up our burr. And then we did a double stent technique, a DK crush, in this very heavily calcified vessel, only after we had prepared the vessel properly, and the final result was quite good. This is the final result with DK crush. I'm sorry you can't see anything. And this patient, actually, we had to do rotablation in a previously deployed stent which had not opened properly. And after that, so there was this dog bone effect left during the previous PCI. So we had to tackle this with rotaburs. And after only a proper job did we open up the vessel and deploy our stent. So let me go to the last case, actually. Now, this is a case where what happened is that this was a heavily calcified LAD. We managed to open up the LAD CTO with a Conquest Pro wire. Now, once we've opened up the vessel with a Conquest Pro, our plan was to take the microcatheter, exchange the Conquest Pro for a rota wire and do rotablation. But our microcatheter would not go. Now, what to do? We tried with a Torners, we tried with the extra support with a balloon, anchor balloon in the L6. We tried with a caravel, nothing would go. So what we did is we parked our microcatheter at the proximal end of the vessel, removed our Conquest Pro, and we maneuvered gently our rota wire through the microchannel that was present there, which we had created with the Conquest Pro. After we had put our rota wire, we were in business, and we did rotablation, and the vessel opened up well. We did pre-dilatation, and this was the final result that we obtained. And we like to call this our NHF rota technique, but I'm sure others have done it as well. So this was the final result where even the rota wire had great difficulty in going, but the microcatheter was not going. So very briefly, let me go through our experience. So up till December, we've done a total of 318 cases. Of these patients, 75% were above the age of 60. Of these patients, 31% were above the age of 70. We've analyzed 288 of our patients. 72% of them were male. And these patients were really sick. 64% were diabetic, and 63% had chronic kidney disease. And regarding the type of lesion, 86% had diffuse calcified lesion, and the mean length of the lesion was 46 millimeters. These were complex lesions. In 104 patients, it was left main. We had CTOs, we had post-CABG, post-PCI patients. We did a multivessel rota in 50 patients, And in the multivessel rota cases, we had more of bifurcation, osteal lesions, and left main cases. We've managed to follow up our patients, mean follow-up period being 32 months, and 83% of our patients are doing well. Our overall MACE is 16%, consider complexity, which is very acceptable. And regarding the death of our patients were really hit hard with the first wave of COVID. In fact, 61% of our patients died from non-cardiac causes, and 32% of these were documented COVID cases. So we've published our experience in a couple of journals, and in summary, I'm sorry I could not show you the cases, but in summary, we would like to say that PCI patients are becoming increasingly complex with more calcification, and calcified lesions obviously have lower procedural success and higher complication rates. Rotablator can facilitate procedural success, enabling the treatment of otherwise uncrossable or undilatable lesions. And in conclusion, I would like to thank our entire team because they make it possible for us to do complex cases. Thank you.